Thanks, Dr. Rogers. Good morning, everyone. So you heard you heard two fabulous talks on cardiovascular kidney metabolic syndrome. What I will do is talk a little bit about what guidelines tell us how we actually assess risk in these patients and how do we manage these patients. So, there's a saying in cardiology that science tells us what we should do, guidelines tell us how we should do it, and registries tell us how we are currently doing. So you actually have seen some of that already from what Dr. Pandey showed, what Dr. Rogers showed earlier from registries, how we are currently doing, right? Science tells us what we should be doing. And what I'm going to give you is basically just a framework. You will hear a lot today. I believe this presentation will probably summarize some of those concepts in a conceptual framework that might make it easier for you as you're going through these various talks, which are extremely, extremely well curated. I must tell you, actually, I am looking forward to a lot of those to learn about those very, very important upcoming topics. My job is to provide you a conceptual framework that might allow you to absorb all of that information. And you'll see throughout these presentations, there's going to be a lot of repetition. And I think that repetition is needed because there's going to be a lot of information. So what I want to get out of this talk is basically three things. Again, to discuss with you major principles in assessment and treatment of cardiovascular kidney metabolic risk. I'll call it CKM risk going forward. I'll give you a four-step approach that summarizes anything and everything you will hear today. If you remember that mnemonic that I will show you, it will probably be easier for you to follow along as we have multiple speakers talking about some very, very novel concepts in CKM syndrome. And then I'm going to give you my take on 5 overarching themes that are important when we talk about CKM syndrome. Some of those you've heard already. I'll probably extend those themes a little bit and add a couple of other themes. So what I will tell you, this has already been shown, is something that came into an American Heart Association Presidential Advisory Committee. There were actually 3 work streams of that. I was part of that, and I was part of the risk assessment group that came up with a new risk equation to assess CKM risk. So I'll talk about all of those things. Now, when we talk about how we should conceptually look at this CKM syndrome, it's basically 4 steps. Screen for CKM risk, assess CKM risk, determine CKM risk, and then reduce CKM risk. So just like any busy academician these days, I asked one of the generative AI softwares to give me a good mnemonic. Why waste my brain cells on that? So of course, what I got was this framework as SAD risk reduction. So screen, assess, determine, and then reduce. Now, of course, any risk is really not a happy risk. Risks are assessed generally for bad things in life. But if you just remember this mnemonic, SAD risk reduction, I think anything and everything you hear today will probably fall into one of those 4 steps. Screen risk, assess risk, determine risk, and when you've done these 3 steps, try to reduce that CKM risk. So let's start with the first one, which is assessing this risk and screening this risk. Now, screening happens both in childhood and adulthood. I'm going to just give you some principles. This advisory has all of this information, all the charts, all the tables, and the slides for your consumption. So I won't be able to get into the details of this, but I'm going to give you some overarching principles. When you talk about screening, what we need to remember is that screening not only happens in adults, it happens in children as well. So remember that, because a lot of time is wasted, and I'll show you why it is important not to wait till people are in their 30s, 40s, and even worse, in their 50s to assess this risk. It starts very early on, and I know we have quite a few pediatricians sitting in the crowd. They will probably understand that this is all written, but a lot of this does not happen. Look at the age when you start actually assessing CKM risk with various risk factors and risk markers that we know when we treat them work. When you talk about adults as well, There are multiple things, and here you will see that we expand that a little bit. I'll highlight a few things, a few new terms here. FIB4 index, which is used to be a marker of fibrosis in the liver, but now actually is coming out to be a very important marker for cardiovascular disease. We have the term MASLD here. Again, that term keeps changing. Now it is metabolic dysfunction associated steatotic liver disease. We'll have a talk on that as well. Now, you will notice that this does not talk about only eGFR screening. It also talks about urine albumin creatinine ratio. And I'll tell you, if you look at the most recent risk equations, the risk for ASCVD, but especially heart failure, really tracks with a lot of these novel markers. So we need to make sure that we assess this risk appropriately and completely based on the patient's risk factor profile. The other overarching principle, which you probably have already picked up in the last two talks, is that the guidelines and the statements are now telling you that we need to formally assess social determinants of health, right? Disease should not be dependent on a person's zip code. Unfortunately, it is. So you will see that there are various tools available now where you can formally assess social determinants of health. One of these tools that I've highlighted here, which is from Oregon, Community Health Information Network. This actually can be incorporated into an EHR. And the other two that I've highlighted here, the Health Leads and Prepare, these are done in a way that these can be part of your regular workflow. So do not slow you down when you have to see 35, 40 patients in one session or in one day, depending on your practice. So remember that screening does not only stop at screening for risk factors. It goes beyond those risk factors to also assess social determinants of health. And I'll come to this over and over again as we go through this talk. So that was the first step. Now, when we have done screening, the second step is assessing that risk, right? You've done your risk factors, you have assessed for social determinants of health. Now, how do you put a number in terms of what is this person's 10-year risk of cardiovascular disease, right? That's second step. And here, American Heart Association most recently developed a new risk score. You all might be aware of pool cohort risk equations, which came out in 2013. Now those have been modified to a new risk calculator called Prevent Risk Calculator. There are a few things that you need to know. This is going to be fairly quickly incorporated into the guidelines, but there are some things you need to know. We knew from pool cohort risk equations that they did not do very well in young people. Actually, you had to be at least 40 years old to have a calculation of your 10-year risk. These prevent equations now allow you to calculate risk in people as young as 30 years old. It goes from 30 to 79 rather than 40 to 79, which is what pool cohort risk equations did. So now you can start calculating risk early. It gives you a 10 and 30-year risk of cardiovascular disease. That 30-year risk is extremely important when you are assessing risk in a young person. You can have a 35-year-old with diabetes, hypertension, hypercholesterolemia. You measure their 10-year risk, it's still going to be very low because you need some marination over time. So, but if you calculate their 30-year risk, it's going to be very high. So it will allow you to then say, what do I need to do to reduce their long-term risk? And that's why 30-year risk becomes extremely, extremely important. And remember, none of the risk equations are perfect. You have to look at the patient sitting in front of you, and that's where reclassification using some risk enhancing factors, which is also the concept with pool cohort risk equations, is there as well. Now you might ask, why do we have to do a risk assessment, right? And again, this slide gives you that concept. Let's say that you reduce blood pressure by 5 millimeters of mercury or reduce cholesterol in someone by 1 millimole, about 39, 40 milligrams per deciliter, the same amount. But if you have a patient whose baseline risk is high, the absolute risk reduction you will get is much more for the same amount of risk factor reduction, any risk factor you look at. So it allows you to prioritize therapy in those patients who are going to derive the most benefit from that therapy. And that is the reason that we do risk assessment for anything in cardiology, whether that's heart failure, atherosclerotic cardiovascular disease, or AFib. The other things you need to know, this is a very nice study that was done by a group in Cleveland looking at pool cohort risk equations. And it's very interesting. If you look at neighborhoods that are very affluent, pool cohort risk equation does fairly okay. What happens when you go to least affluent neighborhoods based on a marker called NDI, a neighborhood disadvantage index? What happens? Look for any predicted risk. The observed risk is much higher, meaning that your pool cohort risk equations were underestimating risk in those neighborhoods that are socially disadvantaged. So there is something about social determinants of health that's actually driving that cardiovascular disease risk. So now you will see that PREVENT tries to address that by incorporating patient's zip code in extended model as well, by incorporating what we call a social deprivation index that's available publicly, and you can have it for your zip code. So remember that it's not just by biology of the disease, it's the social side of disease that can sometimes be even more important than the actual biology of the disease. So now when you look at PREVENT equation, these are the things that are in the base model. So you have the option of just using a base model, or you can use an extended model when you have other variables available. So you have age, you have sex, you have blood pressure, cholesterol, you have medication use for the first time, you have antihypertensive medication use, and you have blood pressure medication use as variables. You have presence or absence of diabetes, tobacco use. You also have kidney function for the first time in your base model, because we know that both GFR and microalbuminuria predict both ASCVD and heart failure outcomes. And then you have an extended model where you can put down urine albumin creatinine ratio into that model, hemoglobin A1C. And when you have SDI, which is a neighborhood disadvantage, so social deprivation index, you can put that down as well, and you will see that the numbers will change. 10-year risk for a patient for ASCVD or heart failure will change based on that. The other very important thing that you need to understand is that pool cohort risk equations only gave you a 10-year risk for atherosclerotic cardiovascular disease, so coronary heart disease, stroke, and mortality from those. But we know that heart failure prevalence and incidence is growing. PREVENT equations actually give you total CVD event rates. So you can have a total CVD event rate that includes ASCVD and heart failure, and then you can have separate number for ASCVD and a separate number for heart failure. So you can now target total CVD rather than just atherosclerotic events. So this is an online calculator that's available. If you actually Google PREVENT risk equation online, you can go online and calculate anybody's 10-year risk. And I give you some examples here. So I put down 77030, which is Met Center, on a 55-year-old female with average risk factor profile. And you see that 10-year risk that's calculated for total CVD is 8.1, and 30-year risk is 35.8. Look what happens when I just change it to a zip code for a town that's about 3 miles from here, where I used to live. I don't live there anymore. But look what happens. Your risk actually goes down by almost 1% just by changing your zip code, right? And by the way, those of you who are very smart would have figured out that your treatment threshold of 7.5% actually falls between those numbers. So this is why these things are extremely important. So now you have a risk calculator that is also incorporating social disadvantage. Of course, this is not end all be all. This assumes that everybody in that neighborhood has the same kind of social profile. And we all know that even within a zip code, there is a lot of heterogeneity. So this is a work in progress, not the end all be all. But we know that anytime you take a risk calculator, it works well in the broad general population, but then there are things where it underestimates risk and there are things where it overestimates risk. And that's where a clinician-patient discussion is important, looking at the actual patient who's sitting in front of you. So if a patient has chronic inflammatory conditions, lupus, rheumatoid arthritis, right? They have high-risk socio-demographic groups. If they're living in areas that are socially disadvantaged, you have a South Asian patient in whom these risk scores do not work, it will underestimate risk. So don't just look at the number, look at the person sitting in front of you. Mental health disorders, sleep disorders, for women, history of premature menopause, adverse pregnancy outcomes, all of these increase your risk of ASCVD and heart failure. So it's important to keep those in mind. So this is a table showing you the differences between pool cohort risk equations and prevent equations. But I want you to understand that now you can pick up total CVD, not just ASCVD. Now you actually do not put race down. Remember, pool cohort risk equations were race-based. So you had a separate equation for African-American males, African-American females, white males, and white females. What prevent is doing is saying that race is not a biologic construct. It's a social construct. And that's why we have SDI and we don't have separate equations for African Americans as we used to have. So whole science has turned now where we don't look at race as a biologic construct. We look at it as a social construct. And remember that with prevent, we're going to be able to calculate 10-year and 30-year risk of total CVD events, which includes ASCVD, but in addition, also includes heart failure events. So again, these are the key takeaways. It's a large sample, by the way. This prevent equation was derived from 3.3 million patients in the derivation cohort, and this was validated in another 3.3 million patients. So it's much more contemporary. It has good calibration, but it has discrimination is very good, but its calibration is very good. For example, in pooled cohort risk equation, one of the issues we had was that it overestimated risk quite a bit. That has come down with prevent. Still, there's a lot of work that needs to happen. And again, we talked about heart failure as an outcome, 10-year and 30-year outcomes. It uses age on a linear scale rather than years of follow-up, which allows you to calculate risk in somebody who's 50, 60, 70. It's a statistical technique to take care of that. And we talked about using a social disadvantage-based measure, SDI, which allows you to incorporate some of the social determinants of health, although there are limitations of using SDI as well. So that was the second step. Remember, we talked about screening. We talked about assessing risk. The third step is to determine CKM risk. And you saw this slide earlier as well. So now American Heart Association says that once you've done these two steps, put your patient down into one of these 4 stages of CKM risk, or rather 5 stages. Stage 0 is no risk factors. Stage 1 is access or dysfunctional adipose tissue. So remember, it's not just having a high BMI. If your BMI is normal, but your hemoglobin A1C is abnormal in impaired fasting glucose range, right? Then you still are in stage 1 of CKM syndrome. And that might be relevant to people like me from South Asian descent, where we may have normal BMIs, but I may be carrying a hemoglobin A1C of 5.9 or 6. So remember, it's not just access adiposity, it's also dysfunctional adiposity. Stage 2 is when you have your traditional risk factors and you have chronic kidney disease that's not very advanced chronic kidney disease. Stage 3 is when you have subclinical ASCVD, as seen by using a calcium score or a CT angio, subclinical heart failure and an echo by your structural issues, your ejection fraction is low, but you don't have clinical heart failure, or your E over E prime ratio is high, or you have markers of heart failure. For example, NT-proBNP, high sensitivity troponin I and troponin T. If those are elevated, those are all stage 3. Or if you have a 10-year risk that's very high, more than 20%. All of those are in stage 3 of this algorithm. So is end-stage renal disease, stage 4 and 5. And stage 4 is when you have clinical CVD, and you have all of those syndromes from CVD listed there. So remember, once you have done your screening, you assess, you determine. And the last step, and by the way, regression can occur, so there's hope here. It doesn't mean, at least from the first 3 stages, you can go from stage 3 to stage 2 if you control your risk factors. You can go from stage 2 to stage 1 as well. And if you're in stage 1, you can go to stage 0 if you take care of the excess adiposity. So there is hope here as well, at least before stage 4. So once you've done these 3 steps, screen, assess, determine, then you talk about reducing CKM risk, because now you know what you're dealing with. Now, if you go through this presidential advisory for each of these stages, you have treatments listed. I'm not going to get into the details of this because this is what Dr. Ballantyne is going to be talking about in terms of therapies to reduce CKM risk, and you heard some of those therapies already. But remember, stage 0 also means that you have to work on a good lifestyle, and I'll show you some slides on why that is important. Stage 1, again, you work on weight loss, and we have a lot of therapies available to us at our disposal now. Again, Stop Obesity Alliance Toolkit is very good. Take a look at it. It will give you some practical steps on how to address obesity in a very non-judgmental way when you're talking to a patient. In stage 2, you start basically treating various risk factors. And you have all of those things listed here, whether that's hypertension, hypertriglyceridemia, metabolic syndrome, CKD. We have a lot of therapies. But remember, therapies only work when patients use them. We prescribe and patients use. Both of those things have to happen. Stage 3, again, you have ways of dealing with subclinical ASCVD and subclinical heart failure. And stage 4, when you have clinical ASCVD, we have a lot of therapies as well that we need to make sure our patients are receiving. So again, I'll summarize this risk algorithm that we're calling SAD risk reduction: screen, assess, determine CKM risk. Once you've done these 3 steps, then reduce CKM risk using therapies that are proven to improve cardiovascular outcomes or quality of life using measures that are extremely well validated. So that was those were the first 2 learning objectives. Talk about the scheme that makes it easy for you to remember the various talks that we're going to have. But there are some overarching principles here as well. The first is that when we're looking at CKM risk, let's not restrict our thinking to 40-year-olds, 50-year-olds, 60-year-olds. It's a life course approach. It starts actually at birth, and I'll show you some data that it starts even before somebody is born. And remember that screening has to happen very early. We should not be waiting for having somebody get their first lipid panel or first glucose or blood pressure check when they're 35 or 40. It all starts much earlier. Now, of course, there is this concept of primary prevention, where you're trying to prevent events in those who basically already have deranged risk factors, right? Then there's this concept of primordial prevention, where you're actually trying to prevent a person from developing a risk factor. For example, in my area that I work in, which is lipids, when a child is born, I mean, the LDL cholesterol levels are not 120, 115, what is average for adults. It's almost half of that. We pick up a lot of that in our early years of life, right? And that is probably the burden that's acquired burden of lipids or atherogenic lipoproteins. So there's a lot we can do even before somebody turns 20 or 22 in terms of reducing the risk associated with that, and that's primordial prevention. Well, my question to you is that can we have pre-primordial prevention? So doing prevention for a child even before the child is born, and the answer is yes. These are data from one of the very large studies that actually looked at mother and child pairs, more than 4,000 pairs. When a child was born to a mother, all these women had glucose checked during their pregnancy, and their glucose, even when it was in the normal range, was associated with overweight and obesity in the children, whether you look at just obesity, body fat, waist circumference. So what mother had, and these kids were on average about 11 years old. So 11 years later, what was mother's sugar during pregnancy had an impact on all of these measures of adiposity in the child, even when you adjust for maternal BMI. So these things start early on. What happens with maternal preeclampsia? When you follow these kids, this is a meta-analysis showing that on average, systolic blood pressure in the first 5 to 10 years of life in these kids is 2 millimeters of mercury higher if mother had preeclampsia, and so is diastolic blood pressure. Can you see structural changes in these kids? These are kids 2 to 10 years of age when their mother had preeclampsia, if you look at their pulse wave velocity as a marker of arterial stiffness, that was high in these kids at 2 to 10 years of age. A lot of you have seen this phenomena of genomic imprinting, right? That is what's happening here, that the genes in these kids are affected by what's happening in terms of metabolism in the mother. And by the way, there's some very early data that it affects, even because it's methylation related, it even affects grandchildren for a mother who's pregnant, whose risk factors may not be very well controlled. So there are intergenerational effects here as well that we're talking about when it comes to CKM. Just by focusing on the mother during pregnancy, we can do a lot for the next 2 generations. So a lot there to achieve. The second principle is to reduce CKM risk early. Let's avoid this analysis paralysis approach. Have a risk factor, treat it. And this is again a very commonly used slide. When you reduce LDL cholesterol by a medication in someone by about 39-40 milligrams per deciliter, about 1 millimole, your risk of having coronary heart disease goes down by 22%. But what if this person had lifelong lower levels of LDL cholesterol because of genetic polymorphisms by the same degree, 39-40 milligrams per deciliter? Their risk is down 54%, more than twice what you would by giving a medication. And why is that? This is just area under the curve. This person had lifelong lower levels of LDL cholesterol. So when somebody has high levels, treating those people early on gives you that much more benefit. You receive that much more dividend out of it by treating risk factors early on. So I think one other message is to start early. Again, the next is don't underestimate the power of a good lifestyle. These are data from various consortia showing that even when you look at polygenic risk score and somebody's polygenic risk score is high, if you can focus here, and you look at coronary artery calcium score in those patients, 50% of that risk can be cut down by a good lifestyle. So if you see people who have good lifestyle versus unfavorable lifestyle, those who have high polygenic risk score, even in those patients, that risk can be cut down by half, despite having bad genes, by having a good lifestyle. What happens to cardiovascular disease events? Again, those events can also be cut down, despite having bad genes, by almost half by having a good lifestyle. Look here and look here. The events are almost half in those who have good lifestyle. The second to last message, let's ensure that the benefits of CKM prevention are not dependent on our residential zip codes. You're going to see this theme over and over again today, and this is unacceptable. On your right-hand side, we have overall social vulnerability index by zip codes, one of the markers of social vulnerability in our country. And then you have on your left-hand side, premature cardiovascular disease mortality. Can you make out any difference in the color scheme here? It's the same. So overall social vulnerability is driving premature cardiovascular disease mortality as well. And look at our state as to how things are. We are not doing too good, both in terms of social vulnerability and in terms of premature cardiovascular disease mortality. So again, we've talked about this, social determinants of health. I'm not going to talk more because you all know that there are disparities. The last concept here we have is that CKM is a team sport. Don't try to take care of it on your own. And I'm giving you some data here that when you involve nurses, pharmacists, social workers are part of that as well. Your blood pressure is on average 5 to 9 millimeters mercury better. Your A1C is about 1 percentage point better when you involve your pharmacists or your nurses. So let's not try to do it on our own. Let's leverage our entire team of clinicians who can allow us to take care of those patients. The other side of this is what was mentioned earlier by Dr. Rogers. Look at it from a patient's perspective, and we say, go to your nephrologist, go to your cardiologist, go to your endocrinologist, go to your diabetes education specialist. What is the patient going through? And that's why there is this concept of CKM coordinators, right? To basically harmonize care across these specialists as well. So I hope that we can look at some of these overarching principles as well as we're having our conversations today and tomorrow. So here are my take-home points. Screen for CKM risk throughout lifespan. assess CKM risk using prevent equations, determine CKM risk using 4-stage classification, and reduce CKM risk, which we're calling the SAD risk reduction approach, address social determinants of health, a key predictor of premature CKM mortality, take a lifelong course approach to CKM risk. Don't just focus on older adults or those who are 40 years old. Start early, leverage entire CV team, and make sure that primary care and subspecialists are working together to address CKM risk. Thank you, and I'll leave you with one message for your patients in 4 lines that summarizes CKM. This is something I've used before. I think I got it from Twitter, so I do not know who is the actual person. It says it's a Tibetan proverb. The secret to living well and longer is eat half, walk double, laugh triple, and love without measure. The last 2, by the way, are not in the guideline.